Good afternoon and welcome to the Rosalind Franklin University of Medicine and Science 6th Annual Women in Science and Healthcare Symposium, Intersectionality Under the Microscope. I'm Christine Burgess from the College of Health Professions Physician Assistant Program and co-chair for the WISH Symposium, along with Dr. Lise Elliott from the Chicago Medical School. We are delighted to have you join us today as we discuss the very important and timely topic of intersectionality. It is now a pleasure to start the WISH Symposium by introducing the President and CEO of Rosalind Franklin University of Medicine and Science, Dr. Wendy Rheault. Thank you, Dr. Rheault, for joining us today.
Thank you so much, Christine, and thanks to you and Dr. Elliott for organizing this wonderful event. We launched the WISH Symposium in 2016 to shine a spotlight of the accomplishments of women scientists and clinicians. And over these years, we focused our lens on issues like the gender divide in the healthcare professions and sexual harassment that too many women face in their workplace. This work has been led and coordinated by the WISH Symposium Planning Committee, and I want to thank each and every one of you for your hard work and contributions to this very important topic. Our journey towards eliminating these factors continues today as we explore intersectionality, the combined impact of sexism and racism. We know that these negatively affect the mental and physical health of women in society and in our professions. Progress demands that we educate ourselves and others on the insidious nature of microaggressions against our colleagues of color. We must provide the support and resources that are needed to move the world beyond the limitations presented by intersectionality. Today, I'm very pleased to introduce Rosalind Franklin, who serves on our Board of Trustees and is the niece and namesake of Dr. Rosalind Franklin. Dr. Rosalind Franklin's experiences with gender bias many years ago, while excelling in research, inspire us to follow her example and work diligently towards a promising future. Rosalind Franklin.
Good afternoon, and thank you, Dr. Rheault, for your kind introduction and for giving me the honor again of providing some opening remarks for this wonderful annual symposium at the university named for my late aunt. Today, the series continues to push the boundaries of what we know, understand, and hold as truths. When I prepare to talk about my aunt to such scholarly gatherings, I always look for new angles, anecdotes, or of interest that might provide additional insight about her character and her contributions to her scientific legacy. On this occasion, I find myself considering new perspectives and notions which may previously have gone without notice. The topic of this year's event made me think about how intersectionality challenges our norms and our assumptions and encourages us to look anew at what we think we understand and take for granted. When you consider all that Rosalind went through in her professional career, I believe that she would have welcomed this year's focus, shining a light on the need to re-examine our systems and frameworks to ensure equality and justice for all. One of the key characteristics of a scientist that she so magnificently embodies, in addition to a curious and inquiring mind, is to be objective, impartial, and accepting of what data delivers. Rosalind exhibited this perfectly in her studies of the double helix. Her magnanimous nature and acceptance of the tested and correct findings of others was an extraordinary quality. She challenged Watson and Crick in their iterative work, but was wholeheartedly gracious and excited by their ultimate discovery. Notwithstanding, she was unaware of the theft of her research, which was the basis of the discovery. This scientific trait, clarity and subjectivity, translated for Rosalind into her personal life, often mistakenly seen by others as standoffish, cold, or distant. But to those who knew her, she was simply exhibiting one of the traits that made her the great scientist that she was. She had the ability to respect another for who they are, acceptance without the need to make herself more comfortable, or to challenge the circumstances surrounding her encounters. A family example of this characteristic is represented by a story my father, who is now 95, loves to share about a surprise visit he paid to Rosalind late one night. He always speaks fondly and admiringly of his sister and remembers her complete acceptance and lack of judgment to be one of the most endearing qualities. My father ran away from school, which is an unfortunate common family trait, in a moment of rebellion. Boarding school has always been an alternative education experience for many English children, and he spent many years at a boarding school in Oundle, near Oxford. Incidentally, since 2017, it has a science laboratory named after Dr. Franklin, at a ceremony which we had the opportunity to attend with two of his siblings, and it was a very memorable occasion. As he recounts the story, he was very homesick, and so felt compelled to remedy the situation by running away. Taking buses and trains to his sister's dorm in Cambridge, he was welcomed with open arms and without recrimination or interrogation. He was so appreciative of the fact that she didn't grill him with questions, asking why he did what he did, or noting how disappointed his parents might be. Instead, she cooked him a delicious meal and made him a comfortable bed to sleep for the night. His parents came to collect him, alerted by Rosalind the following day without drama. This incident stood out for my dad as a pure demonstration of Rosalind's character, one that didn't judge or leap at the opportunity to teach her younger brother a lesson. In these difficult times for our country, judgment of others in our immediate relationships as well as of strangers is rampant. It seems to make us feel better about ourselves, justifying our feelings or creating a reality that works for us. One of the hardest things is to step into a relationship with acceptance without judgment or a need to fix or change the other. We come from a place of fear of difference or of what we don't understand, and it's having an erosive effect on our society. The scientific community strives to rise above this subjectivity, to rely on data, and is committed to the betterment of the health and of the entire population. I know that Rosalind would have benefited from the awareness and changes in the treatment and systems that intersectionality highlights. For during her time, there was no examination or evaluation of circumstances. Consequently, nothing was done in the workplace to support her through the challenges she faced as a fearless, strong, and brilliant, unmarried Jewish woman, though her legacy lives on. So I want to extend my gratitude to the co-chairs of this event, Lise Elliott and Christine Burgess, for including me again in this wonderful occasion and for the opportunity for me to learn and grow in my own understanding. And now it is my pleasure to introduce our keynote speaker, Jioni A. Lewis, PhD. Dr. Lewis is an associate professor of counseling psychology at the University of Maryland at College Park. Her research is focused on investigating the influence of discrimination on the mental and physical health of people of color, with a specific focus on the intersection of racism and sexism on Black women's health and well-being. Dr. Lewis developed the Gender Racial Microaggressions Scale, which is a self-report instrument to measure subtle gendered racism. She also examines protective factors that buffer individuals against the negative effects of gendered racism, such as gendered racial identity, coping strategies, and racial healing. Dr. Lewis has received several national awards for her research and scholarship from the American Psychological Association, including the 2019 Emerging Professional Contributions to Research Award from the Society for the Psychological Study of Culture, Ethnicity, and Race, the 2020 Best in Science Award from the Society of Counseling Psychology, and the 2020 Emerging Leader for Women in Psychology Award from the Committee on Women in Psychology. Dr. Lewis is the current president of the Psychology of Black Women of the Society for the Psychology of Women. This afternoon, Dr. Jioni Lewis' keynote speech is titled, Applying Intersectionality to Center Black Women in Health Equity. Dr. Lewis, welcome, and thank you for joining us and sharing your expertise.
Good afternoon, everyone. It's really great to be here. All right. Thank you so much for that warm welcome. I really appreciate having you here, Rosalind Franklin. I also wanted to thank Dr. Burgess Elliot, Dr. Schneider for inviting me here to be a keynote speaker. I also want to thank, of course, all of the other behind the scenes organizers, Kara, Nicole, and Jay, and many others who I probably have not met, and also to the co-panelists who will be engaging in a discussion this afternoon as well. So I'm really excited to be here and sharing more of my work with you all this afternoon. So the title of my talk is Applying Intersectionality to Center Black Women in Health Equity. Before I get started, I want to provide a land acknowledgement. I first want to start by stating that I currently reside in Washington, D.C., which sits on the indigenous lands of the Anacostan and Natoc peoples. It is important to understand the longstanding history that has brought all of us to reside on this land and to seek to understand our place within the history of genocide of the indigenous people, as well as to acknowledge the current and ongoing colonialism that affects indigenous and marginalized peoples across the country and the globe. It is important to acknowledge that land is a part of who we are and where we come from. It is also important to name the ongoing harms against indigenous people, including the disproportionate negative impacts of COVID-19, the epidemic of murdered and missing indigenous women and girls, and the increased rates of maternal and infant mortality, just to name a few. Beyond just this land acknowledgement, it is also important to support Indigenous organizations by donating your time, resources, and money. It's also important to support Indigenous-led grassroots movements for change and various campaigns that support Indigenous communities. So I encourage others to do so. So the objectives of my presentation today are to examine the concept of intersectionality and how an intersectional approach can be used in healthcare settings, to define the concept of gendered racism and its impact on mental and physical health of Black women, and to identify strategies on how to engage in individual, community, and systems level interventions to disrupt gendered racism in healthcare settings. So I always think it's important to start off and highlight the context that we are currently in with a tale of two pandemics, COVID-19 and systemic racism. Of course, many people know that last May 2020, while we were just a few months into the pandemic, we learned about several high-profile killings of Black people. We learned on May 6th of the killing of Ahmaud Arbery, who was out on a jog in rural Georgia and was shot down in the street by vigilantes. We then learned about the killing of Breonna Taylor. While she was sleeping in her home in the middle of the night, police stormed in with a no-knock warrant and she was shot dead. Then on May 25th, we learned of the killing of George Floyd, and many people also saw the heinous video of George Floyd being killed by police. And I also want to add that today actually is the 1-year anniversary of the non-indictment of the killers of Breonna Taylor's killers. So in many of these cases, we're still fighting for justice. Also, in the midst of this racial reckoning that happened last summer, we know that there are these disproportionate impacts of COVID-19 on communities of color. So Black folks have died at 1.4 times the rate of white people. We also see that Indigenous communities, Latinx communities, Native Hawaiian and other Pacific Islander communities all are more likely to die as a result of COVID compared to white Americans. In addition, we also know that communities of color are more likely to be in essential workers and frontline workers who are also more likely to contract COVID-19 and be at risk of contracting COVID-19. We also know that there are intersections of race and gender. So in December 2020, there was a jobs report, and this was the first jobs report, kind of in this aftermath of COVID-19 that reported that women accounted for all job losses. So that was the kind of initial headline. But when the data were analyzed based on race and gender, it was actually found that Black and Latina women were the predominant groups that lost all the jobs, and actually white women had job gains. Even this image here kind of obscures the difference between white women compared to women of color, because it just has the graph showing women overall. And then you see Black women, Latino women, younger women, and women with disabilities all having higher unemployment rates compared to white men and white women. So what's really missing is an intersectional analysis by race and gender to uncover the disproportionate impacts of COVID-19 and other health inequities on women of color, particularly Black women. So I also think it's important to really highlight the ways that racism is systemic and multidimensional for those who might be unfamiliar with some of these terms and definitions. So racism is a system that includes a structural mechanism of domination combined with a corresponding ideological belief that justifies the oppression of people based on skin color and phenotype and assigns value to people who differ from the dominant white racial group in our country. And there's lots of different researchers in the social sciences broadly, in psychology, sociology, public health, in medicine, who have really talked about and theorized about racism. So James Jones is a social psychologist who developed a tripartite model of racism, where he really broke down that racism includes institutional racism. These are policies, procedures, legal system, healthcare, education, things embedded in certain policies on the institutional level. So thinking about redlining or housing discrimination. Cultural racism, this is embedded in our values, aesthetics, and arts. You can think of, standards of beauty and the ways in which white women are held to a different standard of beauty compared to women of color. And you could also think about individual racism as racial prejudice, bias, and microaggressions kind of is in the umbrella of individual racism, but I like to really talk about it as interpersonal racism. It's what people do with their biases and prejudice in interpersonal interactions. I also want to highlight Kamara Jones' levels of racism. She's in public health. She's talked about institutionalized, personal mediated, and internalized racism. And internalized racism is when people of color can internalize the dominant group messages about their group. My colleagues and I have created the psychosocial model of racism, which really tries to put all of these different levels of racism into context. So just briefly, again, we highlight the structure and ideology of racism. So kind of the structure of racism, and then the coupled with the white supremacist ideology. Those together manifest to be different expressions of racism, including the cultural, institutional, individual, and internalized level. Of course, these things all have impacts on mental and physical health, which I'll touch on in a bit. But it's also important to highlight the resistance to racism as well. There's been a history of anti-racist movements, from the Black Power movement, thinking about the Black Lives Matter movement, thinking about all of the work that people have been doing, particularly in the last year as it relates to this racial reckoning we're in, engaging in these conversations today as a way to combat racism and resist against it. So there's a large body of research on the mental and physical health impacts of racism. So racism is a chronic stressor that contributes to racial health disparities. Many of you probably know this. There's a lot of research on what we call the social determinants of health, right? But more specifically, naming it as racism is that social determinant. There's research in mental health, the impact on mental health, including depression, anxiety, PTSD, psychological distress, right? Experiencing racism over a lifetime, it results in racial trauma. Some people talk about, and there's a body of work on intergenerational trauma and how that shows up in our bodies. And of course, there's also impacts on physical health, such as hypertension, cardiovascular disease, higher mortality rates. And actually, just a few months ago, earlier this summer, the CDC labeled racism as a public health issue and one in needing to do something about. So I also just want to highlight Dr. David Williams and his work. He's been doing a lot of research for over the last 25 years on racism and health. He has a really great TED Talk, if you have not seen it, that came out in 2017. And so on the left is a figure that he created highlighting that Blacks with a college degree have a lower life expectancy than whites with only a high school degree. He also stated every 7 minutes, a Black person dies prematurely in the United States. That is, over 200 Black people die every single day who would not die if the health of Blacks and whites were equal. On the right, there's a more, and that was in 2017. And at that time, it was about three and a half year life expectancy gap between whites and Blacks. This graph on the right shows that the gap has actually widened and is projected to widen with COVID-19 to be a 5-year gap between whites and Blacks. And we also see those gaps when you look based on the intersection of race and gender as well. So Black women experience unique stressors based on the intersection of their race and gender. And this chronic stress leads to a whole host of health inequities, such as increased risk for heart disease, diabetes, increased mortality from certain types of cancer, adverse birth outcomes, and maternal morbidity and mortality. Specifically, Black women are 3 times more likely to experience life-threatening pregnancy complications such as preeclampsia, and nearly 4 times more likely to experience preventable pregnancy-related deaths. And so you can see at the top figure there that it kind of illustrates that Black women, 37.1 number of deaths per 100,000, and then white women is at 14.7, and Hispanic women are at 11.8. In the lower left figure, you see that even higher education does not protect Black mothers from pregnancy-related deaths. So here you see Black women are in orange, and what the arrows are pointing to is Black women with college degrees have higher higher pregnancy-related death than Black women or than white women with a high school diploma. So again, we actually see that with higher educated Black women have just as much of pregnancy-related deaths compared to white women. In 2017, the World Health Organization reported that the US was one of only 2 countries, along with the Dominican Republic, to report significant increases in the maternal mortality ratio since 2000. But often what is missing from this discourse is the role of both racism and sexism in these health inequities. So that leads me to why it's important to have an intersectionality framing to these health inequities. So intersectionality theory is grounded in the Her Story of Black Feminism, which dates back to the mid-19th century when there were women such as Sojourner Truth, abolitionists, and women's rights activists who articulated the ways in which Black women were being excluded from the suffrage movement and being excluded from getting the right to vote. So she spoke at the 1851 Ohio Women's Rights Convention, really articulating her speech was called Ain't I a Woman? So articulating that Black women often were being viewed as not included in the category of woman. So there are ways that Black women were being dehumanized and marginalized in order from white women in terms of getting the right to vote. And of course, throughout the 20th century, there are several Black feminists and other women of color scholars, writers, and activists who articulated the unique marginalization of Black women at the intersection of multiple forms of oppression. In 1977, the Combahee River Collective stated, "We find it difficult to separate race from class from sex oppression because in our lives, they are most often experienced simultaneously." And the Combahee River Collective was a group of a radical Black feminist group of women, many of whom were Black queer women, who really articulated this simultaneous experience of multiple oppressions. In 1989, Kimberly Crenshaw was the first person to coin the term intersectionality when she articulated the unique position of Black women in anti-discrimination law. So she really highlights that Black women who tried to file discrimination lawsuits often had difficulty because they experienced intersectional forms of discrimination. But at the time, a lot of the discrimination law was about kind of single access discrimination, racial discrimination, or gender discrimination. So she really talks about how Black women were really caught at this intersection of both racial and gender discrimination, which then made them more vulnerable because it was hard to really, the law at that time tried to tease apart racial and gender discrimination. So lots of researchers over the last 20 years or ever since Crenshaw coined this term have really tried to figure out how we can articulate intersectionality in our work. But again, often a lot of the work has tried to tease apart and separate racism and sexism. And intersectionality theory is helpful because you could apply the impact of these systems level processes on individual level variables. But there are different ways that people try to apply intersectionality to research. There's what we call the single axis approach. So this is when people try to only look at, again, a single axis of discrimination. So comparing, say, white women to Black women's experiences, which is what a lot of the health data I just shared typically does, right? Or comparing Black women to Black men, right? But again, that's only looking at a single axis of discrimination. Other folks talk about the double jeopardy approach. So this is saying, okay, the combined effects of racism and sexism is double discrimination. But other people talk about the intersectionality approach is really about, again, looking at that actual intersection and better understanding this intersectional oppression that can't easily be teased apart as just race or just gender or any other interlocking systems. And within the field, what I've articulated, the ways in which it's important to have more of a strong intersectionality approach. So weak intersectionality is often trying to just look at intersecting identities, right? Race and gender, and looking at those as categorical variables. Folks talk about strong intersectionality is also looking at the impact of interlocking systems of oppression and really trying to then do something about it, right? Like intersectionality has also always had this focus on social justice and actually trying to do something to dismantle those systems. When you illuminate those systems, you then want to do something about them. But despite the increase in this research, some scholars have recently said that intersectionality has started to become very mainstream and strayed from its Black feminist political and activist roots. And so it's really important, I think it's important to recenter on multiply marginalized groups, and I focus on Black women and their specific forms of intersectional oppression. So I do a lot of my research on gendered racism, which is a term coined by Philomena Assad, who is a sociologist, to refer to the simultaneous experience of both racism and sexism. So Philomena Assad had conducted a lot of research on everyday racism, and then she really also highlighted the ways in which this can be gendered, and it's rooted in racist perceptions of gendered roles and historical stereotypes. So there's a lot of historical stereotypes of Black women that date back to slavery. And then the Jezebel stereotype, this is kind of the sexualized stereotype in the ways in which Black women are objectified in a whole host of ways. And again, all of these stereotypes to objectify, marginalize, and oppress Black women, and they manifest in everyday life. So what are gender racial microaggressions? So again, there's all kinds of overt gendered racism in society, and I try to focus more on subtle gendered racism, the kind of everyday gendered racism that we see. So I often like to give this example. When former First Lady Michelle Obama was creating her Let's Move campaign, there were lots of critiques of it. And one was from former congressman, a Wisconsin congressman, who stated, "She lectures us on eating right when she has a large posterior herself." Now, first of all, I'm wondering why this man was checking out former First Lady Michelle Obama's bottom in the first place, right? But again, this dates back to these historical ways in slavery where Black women's body parts were picked apart, objectified, sexualized in a whole host of ways. Even this image of former First Lady Michelle Obama, often people talked about her arms and how toned her arms were, or kind of lots of commentary about her body. We could also see this play out with professional athletes such as Serena Williams. This was in an article about her where a reporter said, "Williams has large biceps and a mold-breaking muscular frame, which packs the power and athleticism that has dominated women's tennis for years. Her rivals could try to emulate her physique, but most of them choose not to." And he kind of goes on to really highlight how muscular she is, making connotations that she's not feminine, that she's not ladylike, all of these things. And if you remember, a few years ago, after she had a baby, she actually had some life-threatening pregnancy complications. She was having blood clots, and she had to advocate to her doctor to get checked out and they initially try to minimize her concerns. So again, this way in which these kind of things that some people could view as these subtle forms of gendered racism, these ideas about Black women being more muscular, being strong, being able to withstand more, right? We know that there's been research on med students and the ways that med students think that Black people, they still believe stereotypes of Black people having thicker skin, or a whole host of stereotypes about being able to withstand all kinds of pain. Well, how does that then translate to the treatment of Black folks, particularly in this case, a Black woman who's saying she's experiencing pain and something's not right in her body, right? So there's lots of data emerging on the ways that Black women are treated in medical settings and minimized and marginalized, which then could have life-threatening impacts on Black women's health. So gendered racial microaggressions are subtle, everyday, verbal, behavioral, and environmental expressions of oppression based on the intersection of one's race and gender. And I've done a whole host of research really trying to better unpack and articulate gendered racial microaggressions. So I've done qualitative work and interviews and focus groups with Black women. I've developed a scale and done a lot of research looking at the impact on health. So I'm just going to present a few themes here from the qualitative data. So these three core themes that happen. So these projected stereotypes. So these are the ways that people communicate these stereotypes of Black women in interpersonal interactions. And again, these could be both verbally or non-verbally. Silenced and marginalized are the ways that Black women experience microaggressions in professional, school, and workplace settings. This often happens through a power struggle for respect when Black women are in positions of authority, invisibility, sometimes hypervisibility, right? Being the spokesperson, being asked to speak on behalf of one's group, unequal treatment, a whole host of things within that category. And then the third is assumptions of style and beauty, including assumptions of communication styles, assumptions of aesthetics, right? Sometimes people think it's okay to change the way they speak when they're communicating with a Black woman to think that they're connecting, hey girl, hey sister girl, things like that, where they're not ways that they speak that can be really offensive to Black women. And then lots of things about aesthetics. So I'm going to give some example quotes. So this is just a short quote from a Black woman. I always have the stigma of this angry Black woman. And so I have to kind of tone down my passion for whatever it might be. So women talk about, speaking calmly and people assuming they're angry, or sometimes experiencing things and it seems like people are walking on eggshells and communicating with them because they're worried they're going to go off. Ways in which, and this serves to sometimes then silence Black women. So sometimes they don't speak out when they're actually experiencing legitimate issues because they're afraid to perpetuate this stereotype. Again, think about how that might play itself out if you're working with a Black woman patient, or you're teaching a Black woman student, or in a whole host of settings. This is another example quote. So I was bullied by an instructor. She harassed me about what she felt was inadequate in my skills as a health professional student. She wrote me up for minor things that occurred instead of using the incidents for student education. She unfairly applied rules to me in the clinical setting while blatantly ignoring or disregarding the same infractions in other students. And this was a health professional student. I think it was a med student or nursing student who we interviewed for this, who talked about this. So I wanted to make sure to include it in this presentation. And this is assumptions of style and beauty. So it was the first day of class, and immediately when I walked in, the professor made a comment about my hair. At the time, I had the Havana twist hairstyle. He said something along the lines of, "What possessed you to do that? Is it heavy? Is it all your hair?" His outburst prompted the entire class to turn in their seats to observe me. I was very uncomfortable, but I was not ashamed of my hair or my choices. So I calmly answered all of his questions. We each had to introduce ourselves before the class was over. When it was my turn, he again made unsettling comments about my hair. I was angry and felt as if I was made into a spectacle. So again, several key things. I think I wanted to include this quote because it's very descriptive. You can kind of envision this scenario. She was very uncomfortable by all of these questions about her hair, angry, felt like she was made into a spectacle, right? This is very common. Another one is people trying to touch Black women's hair often, an invasion of personal space, treating them, again, objectifying them, treating them like they're, somebody at the zoo, right? Those are quotes that people have said in interviews I've done. Lots of interrogating questions about hair, making them feel inferior for how they style their hair or the way they wear their hair. Sometimes there's also the opposite. Sometimes when they wear their hair straight and they straighten it, they get comments that, oh, it's so professional. And so again, it's like, well, what's the other communication? That it's not professional when it is in its natural state, right? We know that there's the Crown Act trying to prevent hair discrimination because a lot of Black women get commentary that their hair is unprofessional when they wear it natural. And again, think about how that would happen if a doctor makes a comment like that to a Black woman patient. Would she be likely to want to go back to that doctor to seek services? And so, of course, a lot of my work, I have found what we have seen in a lot of the research on racism, that even these subtle forms of gendered racism have an impact on Black women's health. Black women who report a greater frequency of gendered racial microaggressions also report greater psychological distress, chronic stress, depression, post-traumatic stress, anxiety, just to name a few. They also report poor physical health, so poorer self-reported physical health, reproductive health issues, poorer sleep, higher blood pressure, and even cortisol dysregulation, some work on data I'm collecting on a project right now. So again, we see that these gendered racial microaggressions, even though people think they're just subtle or micro, which is kind of a misnomer, it's the everydayness of these microaggressions and the fact that they lead to a cumulative negative effect on the health and well-being of Black women. I've also developed this biopsychosocial model of gendered racism to explore both the direct effect of gendered racial microaggressions on health, but also begin to better understand coping strategies and gendered racial identity and other types of things that could buffer against the negative effects of gendered racism on health. So what I found is for Black women who experience a greater frequency of gendered racism, if they end up having lower gendered racial identity centrality, so they see their race and gender as less central to how they see themselves, often then they don't have the skills equipped to protect themselves against gender racism. So they tend to engage in more avoidant coping strategies or disengagement coping strategies, which then leads to poor mental and physical health. So I like to do a lot of work to kind of see, okay, what are variables and things that can actually buffer Black women against the negative effects of gender racial microaggressions on health? I will say that even when I do and run a lot of these models, we still see a very strong direct effect. So even trying to kind of include other variables, see if there are buffers or those types of things, we still overwhelmingly see that gendered racism over and over has an impact on Black women's health. And so I've also done some research on coping with gendered racial microaggressions and hearing from Black women about how they cope with them. So again, microaggressions are a chronic stressor. And so in each encounter, people have to decide, okay, what am I gonna do about this? So first they often assess whether or not the situation is stressful. Then they have to evaluate their coping strategies and figure out, and what I frame this as picking and choosing one's battles. And for a lot of Black women, they have to make decisions based on the power they have in the situation. If you're experiencing something from your boss, a supervisor, your doctor, right? Someone in a position of power and authority over you, you might respond and react differently than if it's a peer or somebody that you're close to. And so there are these three core ways that women talk about coping with gendered racism. They talk about resistance strategies. So really using one's voice as power, speaking out against gendered racism, resisting standards of beauty. So again, there are these Eurocentric standards of beauty. A lot of Black women talk about, I embrace my curvy figure. I do other things to resist that kind of white normativity of beauty or white standard of beauty. Also engaging in collective coping strategies, so leaning on support networks, creating counter spaces of other Black women to connect with, and that is really important. And then self-protective coping. So again, in the traditional stress and coping literature, they often call this avoidant coping or kind of disparage or passive coping. I call it self-protective because women made very strategic decisions about how to cope in a situation. Sometimes they said they needed to desensitize. They needed to escape certain environments or spaces in places to kind of conserve their energy. Sometimes they did try to become a kind of Black superwoman and overcompensate and work harder to prove others wrong. But again, a lot of women reported sometimes those self-protective strategies are self-protective in the short term, but not always in the long term. So now I want to transition to kind of giving some specific strategies on how to disrupt gendered racism in lots of different ways. So if you're a perpetrator, a target, a bystander, or a perpetrator. So as it relates to disrupting interpersonal gendered racism. So again, gendered racial microaggressions or interpersonal gendered racism. For targets, again, the importance of speaking truth to power, calling out racism and sexism when it occurs, of course, when you feel safe to do so, right? And sometimes we don't always feel safe to do so. Sometimes, again, we have to be strategic in how we deal with gendered racism in our environments. Cultivating counter spaces, as I was just saying, for support, validation, sense of belonging. So in your spaces and places, it's important to think about creating those spaces where you have other folks who understand your perspective, can validate your experiences. But it's also important to take care of yourself and engage in radical healing. So I want to briefly kind of talk a little bit more about my work on radical healing. So I've had the privilege and pleasure of working with just an amazing collective of scholars, Drs. Brianna French, Della Mosley, Hector Adames, Nayeli Chavez-Duenas, Grace Chen, and Dr. Helen Neville. And we've developed a psychological framework of radical healing in communities of color, really to talk about how people of color thrive in the context of experiencing racial trauma. And so often, radical healing is about that process of existing in that dialectic between interlocking systems of oppression and hate, and then envisioning justice and liberation. And there are lots of ways that it's important not to get stuck in always trying to fight interlocking systems of oppression and hate, because that could lead to despair, or always kind of envisioning justice for the future, but not staying in the present moment we're in, where we see that there continues to be so much discrimination and oppression. And it's grounded by 5 anchors. So the first thing is important to develop critical consciousness, to really develop your own sense of awareness and critical consciousness and action about oppression. It's also important to engage in cultural authenticity and self-knowledge, really thinking about the kind of cultural wisdom that people glean in lots of spaces and places, thinking about ancestral wisdom, indigenous practices and ways of healing. It's also important to cultivate radical hope, right? Hope, envisioning for a better future, a place free of racism and other systems of oppression. It's also important to engage in collectivism and social support. And then lastly, strengthen resistance. As I said earlier about the her story of intersectionality, communities of color have had a history of resisting oppression, and it's important to be able to rely on that strength and resistance. And so just briefly, we've also applied this, our model, to Black women. And again, it's important to just name and identify sources of stress and trauma. Really naming this intersectional oppression is key and important. Engaging in mind-body healing. So again, tapping into more indigenous forms of healing or cultural forms of healing. There's a lot of research on mindfulness being really helpful for Black women, or other mind-body practices. Again, support networks are so important for all folks, but particularly for women of color and Black women. Envisioning possibilities for freedom and dignity, and standing for social justice and action. That is healing. That is something, actively trying to do something to dismantle this oppression is really healing and important. And then thinking about how to disrupt interpersonal gender racism so that's all for for Black women and for folks experiencing this oppression. What can bystanders do? It's important to speak up if you're an ally, because often your voice can be heard more than targets of gendered racism. But it's important to not speak on behalf of these marginalized groups or on behalf of Black women, you need to speak based on your own experience. When you hear something that's racist or sexist, you say that it's offensive and why it's offensive to you, not why you think it would be offensive to another group. There's also work, Daryl Wing Su is a psychology professor who's really popularized the term microaggressions, and a lot of that work, he's doing a lot of work on microinterventions. I encourage you to check out some of his work. Again, these are how can you intervene at this kind of interpersonal level. For perpetrators, it's important to educate yourself and increase your understanding of your awareness of your racial and gender biases and your complicity in white supremacy and patriarchy. That I cannot restate enough, right? Like, in order to disrupt gendered racism in all of its forms, all of us need to have ongoing learning and education. We all are socialized in this system. And so we need to do active things to unlearn it. It's important to not get defensive if someone calls you out and they say that you did or said something that was offensive. Try to listen to them, acknowledge their feelings, apologize, reflect, and try to do better. And be willing to, admit when you make mistakes. A part of this work, it's ongoing work. You have to have some cultural humility to understand that you might not know everything about a particular population or group of people or patients you work with, and you have to do work to educate yourself. In terms of disrupting interpersonal gendered racism or institutional level gendered racism, again, it's really important to think about, working on these policies, practices, and procedures that have a disproportionate negative impact on Black women, in addition to Indigenous, other women of color, trying to do something about those policies and practices. Supporting the recruitment and retention of Black women and other women of color in STEM and healthcare settings. Even when I was trying to find some data, it was hard to find data because sometimes it's only broken down by race or gender. Well, we need to look at data based on race and gender. There's only about 2% of Black women in STEM careers. So there's a pipeline issue, right? There's lots of Black women there are more and more Black women getting undergraduate degrees in the STEM area, but then not going on to those STEM careers. So what are things that we can do to try to repair that pipeline to get more Black women and other women of color in STEM? That is essential. And really thinking about not just the recruitment piece, but also the retention. What is happening in these environments that are making Black women and other women of color choose to leave STEM fields? That's really important to think about. Supporting scholarship and training on racism, sexism, interlocking systems of oppression. Refuse to take part and be complicit in racist, sexist policies and practices. Again, often in these days, there might not be specific policies that one can point to that are racist or sexist, right? It's not going to be codified in the law, right? Because that's illegal. But sometimes it's often the practices, how these different policies are applied differentially that lead to certain disparities. It's also important to think about rewriting the curriculum and training, decolonizing what we know about a lot of the things that we've been taught in traditional medicine or in psychology or in other fields. We need to unlearn some of the things that we've been taught and really think about, cultural and Indigenous forms of healing and ways of knowing, and honor that instead of pathologize it. And then, I also want to briefly highlight, I've worked with Dr. Wisdom Powell, who's a public health professor at University of Connecticut, and along with my Psychology of Radical Healing Collective colleagues, on really kind of trying to apply transform our health systems and advance public health policies for radical healing. So we came up with these different principles that we can kind of talk about to transform our health system. So the first is developing critical consciousness of medical racism and BIPOC intergenerational racial trauma. So again, and extending that to women of color, it's important to think about the history of medical racism and the things that have specifically been done to Black women, such as the field of gynecology and the medical racism that has occurred there for Black women. Thinking about the forced sterilization of Black women and other women of color throughout history, right, by the government, by medical professionals. Those things are important to kind of develop awareness about and education and learning about. Principle 2 is sustained organizational commitment to anti-racism and racial justice. It's not enough to pay lip service to it. It's important to do something at that organizational level to continue to be working to change the system. Principle 3, a whole person integrated care approach that increases BIPOC trust and hope. Again, there's been a history of racism. Communities of color, particularly women of color, Black women, have medical mistrust of the medical community because of a whole history of oppression and a history of racism and a history of harm to our bodies. And so what are ways that then practitioners can be mindful of that when they're working with Black women patients to try to overcome some of that mistrust that might be there, right? You need to be proactive in trying to do work to gain the trust of your patients. Principle 4 is robust BIPOC health system supply chain, equity-centered payment models. So thinking about other ways to be able to better serve the folks that we serve. And principle 5, reimagine data and policy narratives about BIPOC health, self-determination, and resilience. Again, the narratives about our communities, thinking about it with COVID, with the vaccine, right? Instead of just framing it as vaccine hesitancy, it's really important to think about why there is vaccine hesitancy. Again, putting it in a proper context. And so I think it's just really important to summarize. It's important to apply an intersectional lens to assess the impact of race and gender in the lives of Black women. Black women have experienced intersectional oppression, namely gendered racism, which has a negative impact on health and well-being. It's important to cultivate radical healing for Black women to survive and thrive within STEM and healthcare settings. As scientists and practitioners, we need to develop these systemic interventions to push for systems level policies to really try to eliminate these gendered racial disparities that impact Black women. And I will breeze through these because I know I have about 1 minute, but in terms of research, we just need to be doing more research on gendered racism and health for Black women. We need to look at other intersections, right? We need to look at intersections with age, class, sexual orientation, gender identity, and other intersecting identities, right? And again, looking at those interlocking systems of oppression, not just the identities. And developing culturally adapted interventions. These manualized treatments, these treatments that this one size fits all approach just is not working well for our communities of color and our women of color and Black women in particular. So we need to actually tailor our treatments to the communities we're trying to serve. In terms of clinical practice, again, can't say it enough, clinicians need to increase their own critical consciousness about racism and sexism and its impact on your Black women patients. Need to try to find ways to connect your Black women patients with healing strategies, other types of interventions, thinking about assessment and intake and how you can really better understand the impact of racism and sexism on your clients. And again, I gotta, really highlight and reiterate the importance of systemic level interventions. It's important to think about, increasing federal funding for research on Black women's health disparities. And I will note there was just a report out today about, there's been an increase in federal funding in the last year in the aftermath of this racial reckoning of 2020. However, what's been happening is a lot of all-white research teams have been seeking out that funding. It's important that if you're going to do research on Black women and health disparities, that you include Black women on your research teams, right? And any marginalized community. It's important to have the expertise and knowledge and experts of those communities and really actively include them in the process of the work. And it's really important to develop this nuanced lens at all stages of the life course in different contexts, because gendered racism affects Black women and women of color everywhere. And it's also important to incorporate Black feminists and intersectionality theory into STEM training, cite the work of Black women scientists and research, teaching, training, and practice. There's a Cite Black Women movement on Twitter, partly because so many Black women in STEM fields and in all fields are often excluded and their work often co-opted. So it's really important to really cite Black women's knowledge. Just want to acknowledge all of my former students that have been involved in my research team, former and current students, and just really thank you all for this time, and I look forward to our discussion.
Thank you very much, Dr. Lewis, for your insightful presentation. I was going to let you know, I especially found the portions of the talk that were on disrupting gendered racism and radical healing to really resonate with me. And I'm sure it really inspired others as well. So thank you very much. So now we look forward to discussing the conversation about intersectionality with Dr. Lewis, as well as our panelists. And we'll also have some time after that for Q&A. Hello and welcome back to the Rosalind Franklin University of Medicine and Science 6th Annual Women in Science and Healthcare Symposium, Intersectionality Under the Microscope. Thank you again to our wonderful keynote speaker, Dr. Jioni A. Lewis, for her enlightening presentation, Applying Intersectionality to Center Black Women in Health Equity. It is now time for our panel discussion, and it's a pleasure to welcome our moderator, Dr. Christian Schneider. Dr. Schneider is an Associate Dean of Research for the College of Health Professions and an Assistant Professor in the Department of Psychology at Rosalind Franklin University. Thank you, Dr. Schneider, for moderating our panel this year.
Thanks, Christine, and thank you, Dr. Lewis, for such an important and wonderful presentation. I know you've definitely given me a lot to think about, and I'm sure that's true of all of our attendees today. So thank you for spending your time with us and staying on for this panel discussion. If you're just joining us, Dr. Jioni Lewis is an associate professor at the University of Maryland. She's also president of the Psychology of Black Women and a leading scholar on intersectionality. If you had to miss her presentation on applying intersectionality to center Black women in health equity, please schedule time in your schedule to make sure that you watch the recording that will be available soon. Before we get to the panelists, I do want to take some of the questions that were posed in the Q&A. We had a question from Jennifer Gomez, who also thanks you for such a wonderful talk, Dr. Lewis. Her question is that in the Disrupting Interpersonal Gendered Racism for Bystanders section, there is an assumption that bystanders are not Black. However, there are Black women who are sometimes bystanders to other Black women being targeted. And she was just wondering about what tips you might have for Black women bystanders of other Black women being targeted.
Yeah, that's such a great question. And I'll also shout out, because Jennifer Gomez also does amazing work on cultural betrayal trauma theory. And so really looking at kind of things that happen, within communities. So really appreciate your question, Dr. Gomez. So yeah, it's a great question. I mean, I think that, anyone could be a bystander to kind of seeing somebody else experiencing microaggressions. And I was thinking about it in this context, if you might be a provider, you might be a doctor or nurse, and you might see the ways in which one of your colleagues treats Black women patients. And I think that is a space and place where using your positionality as a peer or a colleague, if you're seeing that the way they're treating their patients is problematic, trying to educate them about that behavior. I think there's also times when, you might have another Black colleague in your workplace that you're seeing is experiencing something. And I think, it's about being strategic and connecting with certain people that you do feel like are allies, and maybe speaking to somebody that you do feel like has a voice in your organization or in your healthcare setting. That could be another way to try to intervene and engage. It's not always that it has to be, somebody in a position of power or authority to speak up and step up. But again, we know based on, the ways in which our society is set up, that often some people's voices can be heard more easily than others. And try to find ways to get allies. And that's why, honestly, a lot of intersectionality work also talks about the importance of coalition building and connecting with other folks who have other marginalized identities or other points of privilege in order to better work on dismantling those systems. So I hope that kind of answers your question.
I like that a lot. Maybe see it as an opportunity to build community in that experience. Another question we got from RFU's Carl Larson, who really appreciated the Patricia Hill Collins and Bell Hooks citations amongst the others, and was wondering about what common practitioner biases exist in clinical psychology that perpetuate racial, ethnic, and/or gender health disparities, especially for women of color, and what can be done to end them?
Yeah, that's a great question. I think there's so many. It's kind of like, I don't know if I can think of any one, but I think there's lots of practitioner biases that show up, again, at the very micro level, making assumptions about the marital status of a Black woman, assuming she's a single parent, or, making kind of and then being judgmental about that if she is a single parent, right? There's so many things that might happen in the process of working with a Black woman, in a therapeutic setting that could impact the rapport that you would build with a Black woman or other woman of color client. So I think about, again, a lot of those stereotypes, assumptions that I mentioned earlier, making negative comments about a Black woman's hair or aesthetic, those types of things, because again, in our society, we're just socialized that it's okay to talk about women's appearance in general, but then there's unique ways that it shows up for women of color and Black women, that it's really important not to be making commentary about a Black woman's appearance or body size or shape or those types of things. So those are just a couple of examples I could think of.
Yes, probably way too many, and unfortunately an issue that needs a lot of addressing, given how hard it is to get into see mental health practitioners generally.
Yeah, and there's actually a lot of good research on the ways in which microaggressions negatively impact the rapport you're able to build with your patient. So again, I know about more of that research that happens in the field in psychotherapy, but also thinking about how that happens, in a medical setting as well. I think any of us that are practitioners, any of those things that happen in those early interactions could negatively impact that dynamic and whether or not somebody comes back, right? There's a lot of premature termination of therapy and things when you experience that that your therapist or clinician is just not going to understand your perspective or is going to minimize, right? I think another common thing is somebody coming in and sharing their experience with racism and sexism and you automatically minimizing it or trying to use certain kind of CBT techniques that might then seem like you're questioning their reality. Like that's not helpful to do if you, that's just not helpful to do with a woman of color or Black woman client. You want to validate their experience of oppression rather than make it seem like it's all in their head, right?
Yes, absolutely. Well, I just want to pause and introduce our panelists because we do have some great panelists that are going to add to this discussion. But don't worry, for those of you that have Q&A questions, we definitely will have time to get to those. So I won't forget about those. So I'm delighted to introduce our four panelists. We have Ezra Hunter, is a certified physician assistant who graduated from Rosalind Franklin University of Medicine and Science and holds a master's degree in women's and gender studies from DePaul University. They practice in primary and immediate care at the IU Clinic in Chicago and also facilitate trainings on LGBTQ+ cultural competency for students and medical professionals. Welcome back, Ezra. Dr. Heather Kine-Keppel is the Executive Director of Diversity and Inclusion and Deputy Title IX Officer at RFUMS. In her role, Dr. Kine-Keppel is engaged in the development of training and education initiatives for students, faculty, and staff, while supporting the Assistant Director of Inclusion Programs. Thank you for being here, Heather. Our fourth panelist is the future Dr. Lorene Tima Benson, who is a fourth-year medical student at Chicago Medical School at RFUMS, who has dedicated her life to serving underserved populations. Upon completing her undergraduate degree at the University of Illinois, Lorene gained experience as an AmeriCorps Vista volunteer and as a consultant examining communities at high risk for HIV and AIDS. She received an MPH from Emory University before bringing her commitment and expertise to RFUMS. During the past 2 years, she's been working as a United Health Foundation and National Medical Fellow to improve outreach and health service utilization in the local African-American community. Welcome, Lorene. So I want to start, we learned a lot from Dr. Lewis about intersectionality theory and gendered racism. And I'd like to begin with having each panelist share how they conceptualize intersectionality and its connection to systems of oppression. Dr. Kine-Keppel, why don't you begin?
Thank you, Dr. Schneider, and thank you, Dr. Lewis, very much for everything you shared. I'm going to actually draw upon some of your work, if that's okay, as I listened. So I would be remiss if I did not acknowledge my ancestors and all those that survived genocide and colonization in order for me to be here today. And this is significant to my identity and who I am, and I do this in spaces because I believe it's imperative that we acknowledge that, you know, my existence is protest. I'm the first person to earn a doctorate. I'm the first person to be an assistant professor, and I have my ancestors to thank because they sacrificed everything, not knowing that, well, hoping and that we would, that the future generations would be engaged and have a voice. I really want to talk about what Dr. Lewis talked about in regards to her research about silence and marginalized, as well as invisibility. As a Native and white woman, we often find that we are not part of the data. So the land acknowledgement meant everything to me, you know, including Natives and the impact in COVID. And so far too often, we feel extremely invisible. And as an academic, as a faculty member, as an administrator, I think for me, that experience of gender and race and its intersectionality has made me feel that my Indigenous worldviews and frameworks and scholarship is less than, because it doesn't acquiesce into these Western concepts of what is scholarship, right? You know, so me using Indigenous frameworks, you know, really looking at research as ceremony is frowned upon. You know, I'm a qualitative scholar, and even, you know, having to fight to not only use Western frameworks and methodologies, but Indigenous is an ongoing battle. And that is compounded when you read research. So September 8th was equal pay for Native women, right? So on the dollar, we typically make 60 cents. That is our typical pay range. As someone who has a doctorate, I disaggregated the stats and was looking at more research. I make 55 cents, or I and other Native women, and not myself, but we make 55 cents to the dollar for white men who have doctorates. Think about that disparity, 55 cents on the dollar, right? And that, it blows my mind because there's maybe 100 of us that earn doctorates on an annual basis, right? We matriculate maybe 50 people into medical school nationally, you know, on an annual basis. And so knowing that it just reinforces that our knowledge, our ways of being are not valued, you know, and finding those spaces where we can be our authentic self, because I think intersectionality is also bringing all of who we are, you know, to the table, and not having to, you know, like I have to, in order to get published, I have to turn off, you know, my Indigenous paradigms, right? And I think that's it's a hard place to be. And so for me as an academic in a multitude of situations, I see the intersectionality of oppression with race, with gender, with how we view scholarship, and it's like this perfect storm. And then to see the statistics about pay and that it's 2021, for me is just frustrating, right? And so I hope I'm making sense, something I'm very passionate about. But I do think that for me, the silence, the marginalization, and the invisibility is ongoing, right? Like I said, thank you for disaggregating your statistics. Thank you for bringing up Indigenous people in general, because that is not the norm. And so I think for me that just, and I'll leave it at that, but that it just continues to keep on keeping on, and we are disrupting systems. I'm writing 2 chapters for 2 different books, and I'm actually bringing in my Indigenous self. I'm writing about Indigenous assessment, which I was blown away. They're like, we want you to talk, you know, write about Indigenous assessment. I'm like, good. It's going in an assessment book. with other forms. And so, there is hope, but I think that the tenets that you talked about continue to be part of our daily lived experience. And I'm privileged because I'm white coated. And yet I know my sisters and brothers out there doing really hard work. They can't get published. And why is that? Right? Why can't we get into medical school? You talked about the lack of representation in STEM, and again, I'm concerned with my community, but other BIPOC communities, as well as other underrepresented individuals.
Thank you, Dr. Kind-Keppel. Certainly, such a personal issue for you. I appreciate you sharing that experience. Ezra, what about your approach to intersectionality?
Yeah, and thank you, Dr. Lewis, for such a wonderful presentation. It was really enlightening. And Heather, for your comments, I'm so glad that you're here. It's really important that we, have good representation on this panel. I love that. So I think for me, intersectionality, I really learned about that from Dr. Kimberly Crenshaw back when I was in women's and gender studies. So for me, it's useful as a lens, right? It's a model for understanding race and gender and class and all of these things. But it's also a way that we see the world and the way that we see people, patients, and communities, right? So it's a lens through which we can see how power comes and collides in people's lives, right? So for me as a provider, that's really important to not only just identify those intersections for my patients, but also see how does that impact them in terms of empowerment or disempowerment as they interact with the medical system. And then, similarly as Heather, and I'm sure everybody here, I'm trans-identified. So, I have some specific intersections in terms of my own identity, but I'm also a white person, and I'm also very male appearing, even though I use sort of they, them pronouns. So for me as a provider, and I think for a lot of people here, it's really important to have some self-reflection, to locate ourselves within those. It's not only about patients and communities, it's really about us, right? And so when I'm walking into a patient's room, I'm mindful of the fact that they're likely gonna see a white male presenting person, right? Even though I'm trans-identified, that's what I'm bringing into the space, right? That visibility. So for me, that's really what I think about in my work. Yeah, and I'll just stop there. Sure, we'll come back to it. Thanks.
No, thank you, Ezra. Bringing us back to Dr. Lewis's critical consciousness that she emphasized in her presentation. Thank you for that. Lorene.
Hi, good afternoon, everyone. Thank you for having me today. So intersectionality to me, it means when race, it intersects with some other form of identification. It can be class or gender or something like that. And as a result, it pretty much leads to whether or not you're at a power or if you're disadvantaged. And unfortunately for African-American women, we tend to fall in a disadvantaged category. I wanted to just share a few things that I came across. And according to a recent article in the Journal of Women's Health, they noted that Black women on average earn $5,500 less per year and experience higher unemployment and poverty rates than the US average for women. They also noted that Black women are more likely to be at the head of the household than their white counterparts. And they also have to support dependents and have few resources. So that alone puts African-American women or Black women at a disadvantage, just even off start. So for the last 2 years, as was mentioned in my introduction, I've been working to increase African-American utilization and access to healthcare in Lake County. And I found that to be very important because just my background in public health, I have come across, many people, I work with many people who have been disadvantaged, such as those who are uninsured, also African-American women and youth, as well as Latinx women as well. And also those who come from low socioeconomic backgrounds. And from that, I was like, well, okay, what things can I do, even as a medical student, to help bring awareness, to this issue, to see, what resources can be used to actually allow people who are disadvantaged to now start having a way to become advantaged to some degree even information, if it's as simple as getting information can actually put someone at an advantage. Unfortunately, a lot of people who come from low socioeconomic backgrounds, who are born into certain cultures, such as Black culture in America, are automatically just disadvantaged from history. And so to acknowledge those type of things now and to bring to the forefront so people understand, I think it's very important. And one collective organization that I think has done a great job and is doing a great job is Black Lives Matter. As you all can see from the pandemic last year, on its inception, as well as just with this Black Lives Matter movement, many things have been brought to the forefront. So just to have an increase in diversity, I've noticed some efforts have been put in forth to actually do that. So understanding intersectionality and how race is a factor as it plays a role in outcomes, in people's situations, as well as other things that also combine with race, such as class and gender, those things are important to acknowledge. So we're able to understand at least that some people are already at a disadvantage just coming in the door. And so if people understand that, then they won't be so quick to judge when they see someone probably maybe not doing as well in school, or might not be doing or might be certain things going on in certain communities. And instead of just automatically judging and saying, oh, those people are this and that, they need to understand the basis for why things are happening. And I think if you have an understanding for why these things are happening, then you'll be able to see, okay, well, this is what's going on. Now, what can we do to help the situation so that people can have better outcomes?
Thank you, Lorene. Really highlighting the systemic factors that play a role in those disproportionate health outcomes that, again, Dr. Lewis highlighted in her talk. So important, first of all, for us to know about those and to be aware of that before we can actually do something about it. That's great. Dr. Lewis, anything that you want to add to the conversation?
Oh, no, it was great to just hear everyone, really centering and talking about their own positionality and the importance of really, I think each person sharing some aspect of your own personal identities and experiences, I think are so important because, we navigate through the world from our perspective and positionality based on the experiences that we have. And so I think it's important to be mindful of that in all of our spaces. And for many of us who do hold more marginalized identities, also acknowledging, like Heather acknowledged, our privileged identities as well, right? Being in the spaces and places that we're in, our level of education, other things. And so I think intersectionality is both about better understanding our marginalized identities and oppressed identities, but also our areas of privilege, and figuring out ways that we can be working to dismantle all systems of oppression in our various spaces and places we reside.
Thank you. Ezra, you touched on this a little bit in your introduction, but in the work that you do as a physician assistant, can you give us some other examples of how you approach intersectionality to improve patient care?
I think for me, intersectionality helps me, my approach to intersectionality is really rooted in my value of patient-centered care, which for me personally is rooted in feminism. That's where I first started learning about racism and intersectionality, was in the context of feminism. So for me personally, that's where I'm coming in, right? And that's not just about women, right? That's about feminism, is about everybody, right? It's also rooted in anti-racism. So I'm committed to that just as an individual personally, but also professionally. And cultural competence. So, for example, walking into a room, taking a patient-centered approach means that I think that the patient is the expert of their own body, right? I'm trained, I have medical training, but I also know that specifically for people who've been marginalized in medical settings, that their voices around their bodies, like Dr. Lewis was alluding to, this really harmful belief that Black people have thicker skin, that's still being taught, in 2020. I mean, that is just awful, horrifying, right? So it's important for us to bring in that historical legacy, really, of medical racism, right? And that enables us to, really see that people are experts in their own lives. Okay. So that's, for me, that's really important. And then also, just because this is kind of my passion, I guess, is like trans people, LGBTQ healthcare. So I'm always thinking about like the intersections of patients' identities and how that plays out in the kind of medical care that they're getting or not getting. So like, for example, trans men, right? So that's someone who's assigned female at birth who identifies as a male. Well, if that person has a cervix, they need to be getting a pap smear, right? If I'm not aware of that, if I'm not doing what's called like an organ inventory on patients, then that person is going to go without that preventative health care, right? Similarly with like men who have sex with men, MSM, or like trans women, I'm going to screen them for other STIs other than just gonorrhea, chlamydia, hepatitis B, HIV, right? I'm going to add on hepatitis A, right? Like gonorrhea, chlamydia, 3-point testing, right? So yeah, those are just a couple of different things that I think about, kind of just walking into the room and really it's about, I think, seeing the patient as a whole person.
So important. I'm so glad that you highlight the patient as the expert on themselves, right? We need to listen to our patients and so that we can best serve them. Lorene, how about for you? How does your intersectional approach benefit your patients?
I think it's very important to just have the basis and the understanding of intersectionality as a physician or healthcare provider. And that also helps to avoid implicit bias, because a lot of times, unfortunately, when people see an African-American patient that comes in with just an array of health issues, and the patient has probably, they're probably in a state where they might have probably had undiagnosed diabetes for years, and then they're coming in now with all these complications and things like that, they're automatically going to be judged as, oh, this patient is non-compliant, they're not doing all these different things. But then at the same time, I think if there's an understanding on the clinicians end that there is more to, again, patient outcomes than just what meets the eye, if they understand that in addition to this person, being of color, they also have these other, things that also play a role into their overall health outcomes, then, it'll be more beneficial for them to understand that this patient actually has had all these barriers that, they have, are presenting, today with all these issues, not just because they're non-compliant, but because maybe they just didn't have access to get to a clinic, maybe they probably don't have, a lot of money at home, and so the priority is not themselves, but it's on their kids, having food at the table and things like that. And so if there's an understanding with that, in general, then I think even just the care of the patient will be increased, which will further build trust and build relationship between the patient and the provider, and then overall will produce better health outcomes. So I think just having an understanding of how race does play a role into how, people, present at times to the clinic or to the hospital. I think, that'd be better for just overall health outcomes, just with the understanding of the physician and then the patient overall.
Medicine and that should go to my own field, psychology, right? It's more than just understanding the body and understanding the mind. We also have to understand all these cultural factors that play into how people take care of themselves and how they interact in the world. Great comment. Dr. Kein-Keppel, in Dr. Lewis's presentation, she talked about the importance of not just focusing on individual behaviors and individual issues, but also thinking about these larger systems factors and structural factors. And what institutional factors do you see that enable educators and providers to take this intersectional approach to patient care? How can we better set up the system to really support looking at patients with an intersectional lens?
Yeah, and I think that my bias is we need to come to it, and Dr. Lewis talked about this as well, as have colleagues. We need to come to it from a historical perspective and the actual history of medicine and the harm we have done. And we need to reckon with it as we go forward, because like Lorene and others have talked about, patients aren't monolithic. They come with all these different variables, and we need to unpack some of that, so knowing that in my case, between 1970 and 1976, between a quarter to half of all Native women were sterilized throughout the nation. Like, we need those intricacies are important to know, because then we can move forward. And so it's not only knowing the history, but it's embedding it in the curriculum. It's making space and time, and it's making sure that we not only educate our students, but we educate ourselves, and that it's ongoing, that it's professional development, it's training and education, it's interwoven into the fabric of institutions. I always say my biggest dream is that it's so interwoven into everything I do, you don't need me anymore, or you don't need ODI people. I'm not trying to be silly, I'm being sincere. Like, if it can be woven in meaningful ways that are not performative, I think that is amazing. And we're seeing that happen. I think today's conversation, but it's not just this hour with Dr. Lewis and us as panelists, it's carrying the conversation forward, right? So this is not your DEI for the year. What else can we do? And that's going to mean something different for each of us, right? We all respond to things. We all can influence in our each individual ways. And that takes introspection as well as employing empathy and compassion and cultural competence and active listening skills. Sometimes these things we deem as soft skills that actually can save a life, when you're interfacing with people, noticing those nonverbals. So as a non-healthcare practitioner, those are just some of my ideas from the framework I'm coming from, and things I've heard from our students as well.
Thank you for that. Certainly, we all have a lot of work to do. Dr. Lewis, since our students are going to be applying for jobs in healthcare settings, and it can be really hard to sometimes change these structural institutions that facilitate racism and gendered racism in particular, what should they look for to ensure that their employer appreciates this intersectional approach to patient care? What would be your tips for a student that might be on the job market come spring?
Yeah, that's a great question. I think I can think of a few different things. I think first, having a place where you're seeing diversity represented, right, both in your patient population, within the other providers that are on staff, right, like making sure that there's some level of diversity represented there, I think is one thing that's really important. I think also, again, some of what other panelists have already talked about is having an approach where there is this cultural competence and understanding of interlocking systems of oppression, I think, are really important. And so, making sure that it's a setting in place where at least there's conversations or continuing education about some of these issues, where it's interwoven throughout, where there's an attention to working with patients of different marginalized identities, and how you'd be sensitive to that at the very from the very first time you're interacting with a patient all the way through the patient care experience. I just think a place that is doing a lot more of that continuing training and having really open, transparent conversations about these issues is a place that you would know is going to be a safe place. A lot of people, even within clinical counseling settings, a lot of students are looking at internships and things like that right now. And I think about it in a similar way. It's like, you want to be in a place where you don't feel like you have to leave yourself outside of the work that you do. If you feel like you can't bring your whole self into the work that you do, particularly for other marginalized folks that might be looking for employers, then that's a sign that might not be a safe and welcoming space for you. So I think, again, some signs of that, again, is, the kind of diversity of both the staff and the patient population they're working with, and that there's some way that there's ongoing training and education around some of these issues to work on developing competencies, cultural competency. Those are just a few things.
Such great suggestions. Thank you for that. I think we have time for one more question before I go to the Q&A. And I do just want to acknowledge, Lorene, you, as your identity as a student, bring a really unique perspective to this conversation. So what recommendations do you have for how educational settings can address intersectionality for their students?
I just say like a lot of what has already been said by Dr. Keppel and Dr. Lewis in regards to these trainings. I think it's important for the students to start in their first year of medical school. For example, as a medical student now, I'm a fourth year student. I see, many, people have made comments and, in small group discussions and things like that about, their thoughts about, certain, sample patients that we've discussed that have been of color. And I know all of us come from different backgrounds, but I think it's so important to start in the first year class, having like a mandatory course or some type of course incorporated into a course, like a clinical reflections course or something like that, where students learn about, intersectionality, learning about, implicit bias, explicit bias, learning about, prejudices, systemic racism and things like that, and how those things do impact healthcare. Also learning about health disparities and about underserved populations and things like that, because in their third year, they come in contact with such populations, and then with everyone bringing in their own biases, then that can also impact their outlook. But if they start early on in their training, with certain courses and things like that are incorporated, and I believe every year should be something like some type of training in these courses, that way it'll help students by the time that they graduate their fourth year, at least they have a knowledge and an understanding of some things that they probably didn't have coming into medical school.
It's so important for us to be doing this when we're training students, so that we can see positive impacts at the patient level, and hopefully address some of the health disparities that we've been seeing. All right, let's move to the Q&A, because we have a lot of great questions and I want to make sure we have time for all of them. So another question for, I should say, more praise, a well-deserved praise for Dr. Lewis and her great informative talk. And Dima Arbach asks about, you talked about changes in the policies in the educational system, especially science and medicine. Any comments on the role of the traditional hierarchy in medicine that may play a role in suppressing minorities, especially women of color, and the unspoken policies? How can we uncover and resolve that?
Yeah, that's a really good question. And, I mean, yes, there's the traditional hierarchy in medicine, but it exists in so many of our spaces and places, right? It exists in academia, exists in all of these places. And I think, as I said, like actually doing things more proactively to try to get more women and folks of color and other marginalized groups into positions of leadership is really important. So again, it's important to do more things across the pipeline, right? Getting folks from undergrad students that are pre-med or whatever and getting them all the way through, but also thinking about getting more folks in med school and other types of graduate programs, and then mentoring them after that, right? Like mentoring them throughout, I think is really important. We see that there are so many of these disparities that continue and persist, even as we see there's more of a, the diversification of education. There's more folks of color, more women that are getting degrees, but some things happen as they go off and try to get those professional roles and positions. And so trying to do more there, I think, is really important. Yeah, I mean, I think there are so many unspoken policies and rules that I think really shut folks out. I know some, just in terms of thinking about the pipeline, some conversations we're having, which people are probably having in other spaces, is about standardized testing, for example, and the extent to which you use or don't use that moving forward. With COVID, I know a lot of at least grad programs, could have put a pause on using the GRE or MCAT or whatever, but like, what can we do permanently, right? When we see that that's a barrier, or certain exams that need to be taken, when you see that there are certain disparities that exist in who's more likely to complete certain types of exams or licensure or those types of things, then that means there's something wrong with those tests, right? And so what can we do differently there? So I just think about a lot of those things related to the pipeline. But again, it's also cultivating people who want to be in leadership positions. A lot of, I gave a talk a few weeks ago for more of a tech company, but I uncovered some data where it's like a lot of women of color say they want to be involved in leadership roles, but they're not getting those leadership roles. So there are folks that want it. And so it's actually trying to open up the doors to bring more folks through who might be great leaders, but might not be the stereotype of what you think of when you think of a leader, right? So dismantling those stereotypes that a leader is, say, a white cis male, right? And thinking about how to bring more women, folks of color, LGBT folks, more trans folks into leadership roles.
And related to that, are there particular ways that you think are helpful with how do we empower women when we finally get them into those leadership positions, particularly women of color?
Yeah, I mean, that's a great question. I think, again, I often just think about what I talked about in terms of the importance of like counter spaces and the importance of spaces where there can be spaces and places for women in leadership or other underrepresented groups, and getting more of that support. But again, it's also trying to do things for, often people are able to highlight some of the kind of climate issues in their departments or units or spaces or places where, it's like, oh, that person is kind of a bully, or that person does this, or that person. Well, what can we do to change that environment so that doesn't drive people out, right? And I think that it takes kind of bold leadership and folks at all levels of leadership to say we're not going to tolerate certain things. We're not going to tolerate racism and sexism and homophobia and heterosexism in our healthcare systems and in our universities. And I think that's a part of, it's not enough to just say, oh, women need more mentoring and support, right? It's more, how can we change the system to make space and room for folks too?
So important. Another great question, and again, lots of love and praise for you, Dr. Lewis. Lucas Kerstetter is wondering about if you and your colleagues have collected data on the intersectionality and health disparities for biracial Black women or transgender Black women.
Yeah, that's a great question. So in my work, I haven't specifically focused on those communities. In a lot of my work with Black women, it's kind of broadly. So there are some, biracial Black women in my sample. If they identify also as Black, then they usually are included. Same with Black, trans, or femme. Like if they're femme identified, then they're able to be included in my samples and my work. But yes, there does need to be a lot more research on Black trans women, because we know that there are, again, unique intersectional forms of oppression that intersect with transphobia and some of the other things Ezra mentioned in terms of healthcare that I think is really important for us to be thinking about. And so, there are some folks that are doing some great research on, LGBT people of color, and again, looking at the intersections of, racism and heterosexism, but again, also it's important to then intersect sexism as well and seeing how that has an impact. I don't know about I can't name specific people off the top of my head, but I would just say that there's more work that needs to be done in that area for sure.
I'll just add that there are like independent groups throughout the country and around the world that do have some data on trans people, but like what Dr. Lewis is alluding to, it's really, really limited. But I'll just briefly kind of say, like here nationally, there's a National Center for Transgender Equality. So they have, the most recent was the 2015 US Transgender Survey. So that gives us a lot of information around healthcare disparities. And then the University of California, San Francisco, Center for Transgender Excellence, it's a really long name. They're a really, really great resource, as well as the World Professional Association for Transgender Health. So there are a couple, large entities like nationally and globally, but by and large, similarly to, data on Black women and BIPOC people generally, it's really, really scarce data, unfortunately.
Thanks, Ezra. Certainly, again, highlighting that we need more data, more research, and particularly, and as Dr. Lewis alluded to, making sure that when that research is being conducted, that we're including individuals from those populations, that they're the ones driving this research, as opposed to white people with privilege. We've got a question for the panel on what tips for educating ourselves, or what tips do you have for educating ourselves? And we would like clarification on a person's experience as a non-BIPOC person while also being sensitive to the emotional currency this kind of discussion might entail for the person we are asking about their experience. Ezra, do you want to start in terms of this question?
Yeah, great question. And I think that it's so important, like as white people, to be really mindful of the space that we're taking up when we are educating ourselves around racism, for example. And to that point, I think it's really important to have like affinity groups or like processing groups among white people, so that, you know, when you mess up, there's a microaggression or something goes awry, you miss the mark, you can apologize, right? And state how you're going to do better for that person, but you're not going to process that with that person. You're not going to do that emotional processing. That's just really putting more stress and more pressure on people of color and queer and trans people, right? So I would say it's really important. And there are a lot of groups just like locally and nationally, like anti-racist white people who are getting together, who are talking about these kinds of things with other white people. So I would encourage you, and I'm so happy to be a resource outside of this panel. If you want, I can kind of share some of those groups with you. But yeah, that would be kind of my 2 cents just to start off.
Thank you for sharing that. Actually, through a training that Dr. Lewis was a part of, we started accountability groups at RFUMS, and they've just been a wonderful opportunity to do exactly what you're talking about, keep the conversations going, process these experiences. Yeah, it's so important. Thanks for sharing that. Dr. Lewis, any tips you would have for educating ourselves?
I think Ezra answered that question really well. I mean, I just think that, yeah, I mean, it's really about it is about educating yourself rather than, you know, kind of going to that marginalized person and trying to have them be the spokesperson for their whole group, right? You know, often, obviously, if you have a close relationship with a person of color, a queer person, trans person, like that's different than an acquaintance, right? And trying to burden them with questions. But, you know, I think a part of this question here, I also think about, again, this idea of approaching your work with patients with a level of cultural humility and understanding what you don't know. So part of that then means that you're going to ask those questions and be curious about certain things about their experience, because even if you've read in a book, like this is how you go about working with Black patients, you know, this person in front of you has had their own experiences that you might not know, right? And so not wanting to also think that you are able to make assumptions about this group because you've read about it in a book. It's about building that relationship and rapport with your patients rather than making certain assumptions about them. So I think, you know, coming with cultural humility is really important in that process of cultural competence.
Another great question. And Lorene, why don't I have you start with this one in terms of what guidance do you have for engaging clinicians who do not believe that systemic racism, systemic sexism, or other systems of oppression exist? It can put you as a colleague in a challenging position, right? So what guidance would you have if there are clinicians that you're working with who maybe just don't believe that these, even though there's all this data out here that we saw so wonderfully presented in Dr. Lewis's presentation, like what guidance do you have for any clinicians that might not believe that these things exist?
I think one thing that I think that's important is for clinicians to be a part of the conversation. So I've noticed, you know, just in the last year, how many different talks have been you know, presented in regards to, you know, various topics on race and how, you know, that intersects with health. And so I wanted to just encourage clinicians to be a part of those conversations, to at least, you know, be there to listen in on these talks, because a lot of times the talks would have, you know, many people who are on the panel or who are, you know, a keynote speaker such as today's talk that have expertise in these fields and topics and things like that. So I would like to encourage them to, be a part of those talks and to, definitely, put forth the effort and be proactive in following up with, okay, yeah, I've heard about this. Okay, so now this is what's really going on, within my circle, in my hospital or my community or things like that. So I would definitely highly, do that. Unfortunately, I know a lot of things are systemic based. And so sometimes it's kind of hard just to tear down those things, but just even starting with just, attending certain lectures and things like that can be a help to start, dismantling some of these walls that have been built up and misunderstandings.
Dr. Kine-Keppel, anything you would add in terms of the guidance for engaging clinicians who don't believe in the systemic racism and gendered racism?
I mean, I think sometimes the empirical evidence speaks for itself, the health disparities, if we're talking about LGBTQ plus patients, one out of two, and please correct me if I'm wrong, have experienced discrimination. 1 in 2, like that's 50%. And so again, the empirical evidence speaks for itself. It's scientific, it's been gathered, it's not all qualitative, which is my, the stories for me are everything, but it's out there. And I think sometimes that's the foundation where you need to build upon. There are health disparities because of X, Y, and Z. Redlining still impacts so much of this country. And so I think, and it's been documented. So again, it's always, for me, sometimes it's, even though stories are everything to me, it's really relying on that evidence that's there and has been collected. And it's been collected for a reason, and we had a responsibility to share it.
Yeah, I had the same response that, data doesn't lie, right? Like doctors really love data. So that's a really strong way to hit someone if you want. But honestly, I take like a strengths-based approach, like with most things. I feel like there's enough of us in health sciences who are, sort of on the right side of justice, that I'm more interested in aligning myself with those folks and creating community and power around that kind of positivity moving forward than I am convincing people who don't believe in racism. I just don't think that is, personally, that's not where my energy wants to go. Like this panel is so beautiful. There's a lot of people here that there's so much knowledge and experience in the room. I'm more interested in what we can do together.
And I think that coalition community building, the intersectionality of the panel, and that's strength. There's so much strength in that. And so how can we lift each other up, right? So sometimes, like, I don't always want to speak for Native people, because there's no, and so then, a student or colleague steps in for me, and it's fabulous. Like, how can we support each other when we don't have the emotional energy?
What I'm hearing here is we can build this community, build this coalition, and that's a real strength to move forward and start working on dismantling these systems of oppression. Dr. Lewis, we got another question. What would you speak to the concept and process of dismantling racist systems? Like how do we start? Like we've got this lovely community where we've got a common goal. Like where do we put some energy?
Yeah, that's a great question. I think, I often view it as, there's not one right place to start, right? And so as I talked about, kind of oppression happens at these multiple levels of interaction and impact. And I think we all can work to do our part at different levels. So, although, yes, I think it's important to dismantle the system, the system is also made up of people, right? And so we can do things at those different levels of interaction and impact. So doing stuff at the interpersonal level, trying to actually, do things to kind of prevent folks from continuing to, perpetrate microaggressions and other things, that's doing something, right? Again, a lot more of the systemic things that I mentioned, it's about who's in positions of power and leadership in an organization or in the healthcare setting, and trying to do things to make changes there, I think are really important. And I will say it's not only about identity, right? I think that's one thing I want to highlight and stress. It's also about those looking at oppression and power as well, right? Because you could have somebody that checks a particular box in a leadership position, but if they still are approaching the way they lead that organization from a white supremacist patriarchal perspective, then that's not going to actually be helpful to dismantle those systems. So I think it's important to, yes, that helps, having a critical mass of marginalized people and having a more inclusive environment is important, but it's top down, right? And it's not just having some people that look different, sprinkled about. It's really about integrating them into the leadership structure of an organization.
I think that's a great place to end. Thank you so much to Dr. Lewis and our panelists. This has just been a wonderful conversation. It's certainly the start, though, of the work that we need to do here at RFUMS and also in our clinical placements. So thank you again to all our panelists for contributing to this conversation. And Christine, I'll throw it back to you.
Yes, absolutely. Thank you so much to all of our panelists for your really thought-provoking conversation. Dr. Elliott and I would also like to again extend a really big thank you to Dr. Lewis, who spent today with us. As well, thank you to Dr. Schneider for recommending Dr. Lewis to us and for also working with us as our moderator for our symposium. And finally, just a big thank you to our WISH committee for making today's symposium possible, as well as a big thank you to our administration at Rosalind Franklin University of Medicine and Science, particularly Dr. Rheault and Trustee Franklin for their continued support for the WISH symposium. Before our final goodbyes, I'd also like to highlight a few upcoming events in the WISH seminar series. And those are, first of all, on October 13th, we have a virtual session with Dr. Eve Martyr, and her presentation is When to Stay and When to Go. On December 9th, we will have an in-person session with Dr. Amy Gottlieb, and she will be talking about the gender pay gap. And finally, we're also really happy to announce our presentation in January of 2022 with Joy Blumweeny, who will be discussing decoding bias. Also, I wanted to make sure we extend a very special thank you to our WISH coordinators. These are Jay Moat, Kara Bass, and Nicole Ulibri, whose tireless work and impeccable organization ensured the symposium could come together. Thank you so much for all of your time and energy. It's a pleasure for Dr. Elliott and me to work with you. And last but not least, thank you to all of you who joined us today. We appreciate your support for women in STEM and healthcare and look forward to seeing you at our future events. Have a lovely evening, everyone.